Thank you very much for inviting me here. This is, as you can all see, this is quite an amazing group that I've had really a lot of fortune to be working with for so many years and learning so much. And I don't know what the expectations were from MRI, but I'm just gonna take some aspects of it. There's so much to say about stroke and injury. And as a pediatric radiology, I stand between the fetal world and the postnatal world that's also going to be later assessed with Mohan Hoisman. So I'm very fortunate to work with all these groups together with Daphna Ben Basat. And so I will only choose one of the aspects just to show the differences of it rather than talk about all the many aspects that were previously shown. So what we're going to talk now is about ischemia. And as Daphna has shown, in this case, we can really, MR has the capability of seeing beyond just echogenicity. We can really see the tissue characterization. This is an intrinsic advantage that you can really see by the T1 weighted images and the T2 star weighted images of seeing what really is some of the tissue components. And we can also identify it because of the 3D aspects of it. And you can really see that in the same patient, it's more likely as an extraaxial, but probably a sub-PO, which is a very unusual hemorrhage in the neonate. And when we try to look, and I know this has been already talked about previously, but let's just try to make some kind of order in it. We define ischemia to two different timelines and the damage that they cause. The early ischemia that appears in the first and second term may cause schizencephaly, porencephaly, and you saw some beautiful cases previously, but it also may affect the migration of the neurons and cause polymicrogyra or the very extreme cases of hydroencephaly. When the ischemia appears later, and this is into the third trimester, and as you see, we are experiencing a lot of, it really matters where you practice which country you're working. We are seeing a lot of very late abnormalities because of the scanning capabilities of everyone in this group. So the later ischemia, you can see multicystic encephalomalacia, and then you can get atrophy or periventricular locomalacia, or sometimes oliguria, which is a very typical, unusual cortical abnormality that you can see. So if we try to look at all of these abnormalities and classic injuries, we really have at least for prognostic idea, we try to differentiate between what was previously called the classic venous porencephaly, with the dilatation of the frontal horn is the classical one, and the classic arterial porencephaly. Of course, in the early cases, we can see schizencephaly, and the multicystic encephalopathy are quite easy to identify them no matter where we're looking at. So the direct findings of the focal lesions are cavitations, and we can see calcified locomalacia or structural abnormalities. If there's a diffuse abnormality, there's a lot of white matter signal abnormality. Lamina necrosis is something that is more easily detected on MR. And the indirect signs are, of course, the cerebral biometry or the ventricular dilatation. As seen, this is a very old case, but you can see the abnormal parenchyma loss, the dilatation of the ventricles, and the whole problem. Now, I actually wanted to get into this subject from a different perspective, and this is with the help of the neurologist that I'm very lucky to work with, and Mohan will really talk about it. But when we look into the perinatal stroke, and there are many, it has been defined very differently in different times. And when we look at all the children that we previously talked, and they were called that they had idiopathic hemiparetic CP or congenital hemiplegia, right now, because of the imaging techniques and the advances and the increased availability of MR, we can try and trace the markers for it. And it's actually understood that what we are calling periventricular venous infarction has actually been described in children that present with congenital hemiplegia. And it is believed that they represent the same understanding, but in an in utero version of the same venous stroke. And even though they are this is by Dunbar and Curtin, and there's a lot of other articles about it, even though everyone is very careful about talking about the incidence in such small groups of 15 to 5 patients, it appears that the PVI is probably representing about a half of all the presumed perinatal strokes that we are seeing. Now, we all know this concept already 20 years ago I was very fortunate to work with George Taylor in Boston, and the concept that a subependymal hemorrhage compresses on the vein that contains all the blood coming from the medullary veins. And so we see an IVH in the subependymal area of the terminal vein, and this causes congestion and medullary vein and an infarct. So this concept of what we see as not very uncommon in the postnatal world, in the preterm infant, is actually probably happening in a very similar way in the fetus. And the PVI, the periventricular infarct criteria, as seen in these articles on the postnatal world, they include focal periventricular encephalomalacia. There is T2 abnormality, hyperintense signal in the plig, in the internal capsule. The cortex is relatively spared, and this is a really important point in differentiating it from the arterial strokes. There is a remote hemorrhage, and this is another importance of the MRI, because the hemorrhage sequences that we have, the hemo and the T2 star, are very sensitive for these bleed, and the basal ganglia are spared. So this is the typical finding, and this is well described. And they also have a typical clinical abnormality that I'm sure Moran will talk about, mainly more in the legs than in the right. When we look at it, and this is courtesy of Catherine Durrell, this is, as you've seen in the postnatal world, in the prenatal, it's very difficult to catch the exact point of the stroke when it happens. We're in the fetus mostly seeing the consequences of it. Sometimes we are lucky on these T1 weighted images to see the subependymal hemorrhage and the parenchymal abnormality in the typical stroke appearance of the likely a PVL. And I actually wanted to show you the more subtle cases that, in looking in retrospect, and I don't think I had called them like this in real time. And again, they were referred due to increased echogenicity or an abnormal suspected bleed on ultrasound. And sometimes they were referred due to ventriculomegaly or some abnormal contour of the lateral ventricle. And you see this very thin, hypointense T2 signal lining the slightly dilated ventricle. And it really shines out on the T2 star weighted. You may imagine a little bit of thinning of the posterior part of the corpus callosum. And these are really very mild abnormalities. I presume these are the cases that may later appear as hemiplegia or very minimal abnormalities. And this is as demonstrated on the Curtin and Schroff, and you can see the very typical shape of the fourth ventricle and some thalamic abnormalities. This is in the postnatal world. This is another case, another subtle hemorrhage, and I think this may be extending into the basal ganglia and the ipsilateral internal capsule, because you see by the extension of it, it's not just volume average of the ADC map and the diffusion weighted abnormality. And you can see that it all starts from the subependymal area. So really, MR has this capability of helping in trying to look into this understanding. And again, we're seeing it in the postnatal world with a typical caudal triangle that we can see. Now, it's very important from a neurological aspect to differentiate between the cases if it's arterial and clastic. And this is again from the same work of Kirtan in 2008. And when they put together all the kids that had perinatal ischemia stroke, that they thought it was arterial, some of them, not very few of them, were actually PVI with a typical appearance. So looking at the radiology and looking for the typical finding of the blood, you can really try to make this differentiation, which I think is quite not regularly seen. Now, of course, the huge cases that we saw before, when you see the complete huge hemorrhages that fill the ventricles, that look like extreme echogenicity on ultrasound. On T2, you can actually, and T1 and the diffusion and T2 star, you can actually differentiate with a timeline. And this is really important in seeing that they may appear at different times. But when such a destructive process has happened, we're really thinking about the differential diagnosis that I've previously seen. And I think that this is not really something that is hard to, difficult to diagnose. And they all involve, once the parenchyma is damaged, they all involve and become porencephalic abnormalities. This is an old case again. You can see the differences in the images of a very religious family. We did make the correct diagnosis of a huge hemorrhage, a unilateral one with extension into the parenchyma and probably PVI. And this is the ultrasound postnatally, and the postnatal ultrasound MRI as performed afterwards. And this child, on top of having some hemiplegia, is also suffering from mental retardation and other seizures and abnormalities. Just to touch base on a few other differences, if it's before 24 weeks of gestation, if this is going into the early brain injury, when we do not have the ability to have gliosis, then we can develop the very typical schismcephaly. And here we can see on the T1 weighted images a little bit of hyperintense T1 signal to demonstrate some blood. And you can see also the very typical absent of the leaves. These children can present for ultrasound, and they are often defined as that and turned for MRI because of absent leaves of the cavum septum pellucidum as SOD. And it's important to demonstrate the more peripheral aspect of the schismcephaly, which can be very subtle sometimes and not seen very typically. You can see it here. I'm just going to be really short on PVPC, just to touch base on that. And I think it's a very subtle abnormality that we often see, and it's defined sent to MR. I think it's important to understand that we need to differentiate by the appearance of the wall of the cyst and the extension of it, and we can try to see if there's blood products. This is an example, and a very unusual example of abnormality, and that has actually been defined as a pathology in genetics. I just want to present this case to make the differentiation that the periventricular pseudocysts appear in line below the line that extends into the lateral ventricle. And once we see the cyst superiorly, and that, as shown, Professor Malinger has showed in his lecture, when they extend into the deep white matter superiorly, they can cause a lot of abnormalities and damage, and then we're getting into a totally different group. And this is the pathology in this case, and I guess I'm going to stop right here. So thank you again for the opportunity to work with this amazing group of teams of amazing sonographers. And I thank everyone here in this group of all the neurologists, pediatric and neurosurgeons and pathology. Thank you very much.